Hello, everyone. Today I will be speaking about Addison's disease. Addison's disease is a rare acquired disorder which results from primary adrenal insufficiency and a deficiency of adrenocortical, glucocorticoid, mineralocorticoid, and androgen hormone secretion. Addison's disease is the result of an autoimmune process which destroys the bilateral adrenal cortexes of the body. This is known as primary adrenal insufficiency and is the most common cause of Addison's disease, making up for 70 to 90% of all cases. Addison's disease has also been known to arise from infections such as tuberculosis, which makes for 7 to 20% of cases, meningococcal and histoplasmosis infections. Metastatic cancer and lymphoma can also cause adrenal insufficiency and Addison's disease, and then adrenal hemorrhage or infarct. And drug use can cause Addison's disease as well. In autoimmune mediated Addison's disease, humoral and cellular mediated immune reactions are improperly targeted at the adrenal cortex, resulting in adrenal destruction. Individuals with Addison's disease often suffer from polyglandular autoimmune syndromes, which is an autoimmune disorder which destructs multiple endocrine glands. Some of these disorders include type 1 diabetes mellitus, chronic immune thyroidosis, or Graves' disease, to name a few. In Addison's disease, the adrenal cortex is attacked via the process of lymphocytic infiltration, and extensive atrophying of the parenchyma occurs. As the disease progresses, the integrity of the adrenal cortex is diminished, and the 3 layers of the adrenal cortex are destroyed and replaced with fibrous tissue. The degradation of adrenal cortex results in the loss of adrenocortical cells. This leads to widespread deficiencies of adrenocortical secretion, glucocorticoid, mineralocorticoid, and androgen secretion. The decrease in corticosteroid and aldosterone producing hormone leads to an increase in adrenocortico ACTH and melanocyte stimulating hormone, MSH, as compensatory mechanisms. Unfortunately, the body is unable to survive without essential corticosteroids and aldosterone, and individuals with Addison's disease must maintain lifelong corticosteroid supplementation and have an increased risk for mortality and decreased quality of life. Risk factors for Addison's disease are polyglandular autoimmune disease, such as type 1 diabetes mellitus, thyroid disorders, vitiligo, and myasthenia gravis, past tuberculosis infections, decimated fungal infections, HIV infections, syphilis, and African transpomasis are also known to lead to adrenal insufficiency. However, these are much less frequent. Hemorrhagic infarction may result in an acute case of adrenal insufficiency. Those who suffer from meningococemia and highly hypercoagulable states and are on anticoagulant therapy like heparin can increase the individual's risk for adrenal hemorrhagic infarct. Individuals with celiac disease have also been seen to have an increased risk of Addison's disease, and there is presumed to have a genetic link to the autoimmune regulator gene on chromosome 21 with Addison's disease. The onset of disease usually occurs between 30 to 50 years of age. However, it has been seen in teenagers and those in their 20s, and Addison's disease is more common in females than males. Major signs and symptoms of Addison's disease. Addison's disease is known to have an insidious and very vague onset. Oftentimes, symptoms are vague and develop and worsen over time. This can make Addison's disease extremely difficult to diagnose. Patients are often diagnosed when they are suffering from acute adrenal crisis or an Addisonian crisis. Individuals may be observed to have decreased body hair as a result of decreased androgens and hyperpigmentation of the skin, especially on extremities, skin creases, tongue, due to increased levels of MSH. Patients are also frequently observed to have weight loss, anorexia, frequent infections, poor stress response, hypotension, low blood glucose levels, and fatigue. In an acute Addisonian crisis, the patient often presents with symptoms of fatigue, nausea, vomiting, diarrhea, abdominal and back pain, dizziness, hypotension, tachycardia, and syncope. These patients are also, with their lab work, known to be hyponatremic and hyperkalemic, and then hypoglycemic. These symptoms can escalate into metabolic encephalopathy and shock, and eventually death if left untreated. There are multiple diagnostic tests that should be considered for patients with Addison's disease. These include a thorough physical assessment of symptoms. Could be the darkened skin color, anorexia, hypotension, and then checking hormone levels such as cortisol and aldosterone and renin levels. ACTHS levels should also be checked along with corticotropin stimulation testing. MSH is also an important biomarker to test for. Serum chemistries should be checked for hyponatremia, hyperkalemia, and hypoglycemia. A complete blood count should also be obtained for neutropenia, lymphocytosis, and eosinophilia. TSH levels and anti-12 hydroxylase antibodies should also be examined. Imaging studies such as MRI of the hypothalamic pituitary region should be obtained, and chest x-ray should be considered to determine the bilateral enlargement of the adrenal glands, which is often seen in hemorrhagic infarct, and then the destruction of the adrenal gland, which is usually seen in the autoimmune mediated Addison's disease. A PPD test should always be considered just because of the prevalence of tuberculosis-induced Addison's disease, even though it's not as common as autoimmune mediated Addison's disease, but better to check. And then an ECG is also recommended in the case, especially of hypokalemia, and in the case of cardiac involvement from hyperkalemia, sorry. Yeah, so I hope you learned something about Addison's disease today. Here are my references. If you have any questions, please reach out. Thank you.